Welcome to this lecture on pulse oximetry and oxygen delivery protocol, which is our Tech 10 protocol. So let's start off by just quickly recapping the physiology of oxygen saturation. So oxygen saturation refers to the amount of oxygen found or bound to hemoglobin, or found in hemoglobin, in the blood, expressed as a percentage of the maximum amount of oxygen that hemoglobin can carry. Hemoglobin itself is a protein in the red blood cells that binds to oxygen and carries it to the body's cells where it's used for cellular respiration, something I'm sure you've all learned about in biology class. So each hemoglobin molecule can bind up to 4 oxygen molecules through its iron atoms, creating a stable complex known as oxyhemoglobin. The oxygen saturation of the blood depends on the balance between the amount of oxygen being taken up by the body's cells and the amount of oxygen being delivered to the cells by the blood. In healthy individuals at sea level, and it's important to mention sea level because you'll see in our protocol that when we go outside of sea level to the extremes, whether up or down, oxygen saturation is typically between 95% to 100% at sea level. So, which means that the majority of hemoglobin molecules in the blood are carrying the maximum amount of 4 oxygen molecules. When the body's cells are using more oxygen than is being delivered, the oxygen saturation decreases. And when the body's cells are using less oxygen, the oxygen saturation increases. And that's why it's important to understand the concept of left and right shifts in the oxygen hemoglobin dissociation curve, which we will talk about shortly. So factors such as altitude, which I just mentioned, lung function, and cardiovascular health can affect the body's ability to deliver enough oxygen to the cells, leading to changes in oxygen saturation levels. In certain medical conditions, such as respiratory or cardiac disease, oxygen saturation can become significantly lower than normal, leading to a condition known as hypoxia. And it's important to kind of define hypoxia to really understand it, because that's what we are treating when we're talking about supplemental oxygen. So hypoxia is a condition in which the body's tissues are not receiving enough oxygen to function properly. This can be caused by a number of factors, including a decrease in the oxygen saturation of the blood, a decrease in the amount of blood being pumped to the tissues, or an increased demand for oxygen by the body's cells. So an example of the last one, the increased demand for oxygen by the body's cells, you can think of the patient who has cardiovascular disease, who's known to have angina, and they develop ischemic, so ischemic meaning lacking of oxygen, type chest pain with physical effort. So the 64-year-old who decided to go walk up 3 flights of stairs develops chest pain because his myocardium, the cells of his myocardium are increasing the demand for oxygen. But then as soon as they're at rest, the demand goes back to normal and the chest pain goes away. Okay, so that's an example of that one. It's important to understand that there's different types of hypoxia as well. There's systemic hypoxia, in which the entire body is affected. Okay, so systemic, the entire body, and local hypoxia, in which only a specific area is affected. And why we need to know this is because hypoxia can have serious consequences for the body, including cellular damage, organ dysfunction, and of course, in severe cases, death. So it's important to be able to diagnose and treat hypoxia promptly in order to prevent further harm to the body. This may involve increasing the oxygen saturation of the blood, improving blood flow to the tissues, or addressing the underlying cause of hypoxia. So how do we diagnose this hypoxia? Well, we use pulse oximetry. So a pulse oximeter is a non-invasive medical device that's used to measure oxygen saturation. We write it out as SpO2 of a person's blood. It works by shining a light of 2 different wavelengths, a red light and an infrared light, through the skin and onto the blood vessels, and then measuring the light that is absorbed and which light is transmitted back through the skin. So the hemoglobin in the blood absorbs more of the red light than the infrared light, and the ratio of absorbed red light to infrared light is used to calculate the oxygen saturation of blood. So this information is displayed on a small screen on our monitors, which can be updated pretty much in real time, or we say, maximum within a minute, as the oxygen saturation changes. Pulse oximeters are attached to our monitor defibrillators, so our Zoll monitors, and it's essentially one of the standard vital signs that we assess for all of our patients. So different types of pulse oximeters. So here in the top right corner, we have a small one that we can just apply on a patient's finger. You'll see our first responder services use this quite typically. You'll see the heart rate and you'll see the oxygen saturation. and you'll also see a plethora of waveform. The one on the bottom right is one that you might see in the hospital setting. You might see different versions of this. You might see it at triage specifically. And then, of course, we have our Zoll monitors. You can see here the SAT probe is like a rubber type device that goes around the finger. In the bottom right here, a little bit hard to see, but you'll have the oxygen saturation reading there, along with our bouncing bar. So troubleshooting accuracy of our O2 saturation. To ensure an accurate oxygen saturation reading with a pulse oximeter, it's important to follow certain steps. So one, choose the correct finger. The pulse oximeter should be placed usually on the index or the middle finger. It's important to make sure that the finger is clean. We can use an alcohol swab or soap and water if you're in the hospital setting, okay, to remove any of the dirt, oils. Okay, all these things can affect the readings because, again, the lights are trying to go through the skin. Avoiding any movement. So if the patient's moving their fingers or they're shaking, they're trembling, that will affect the accuracy. If they have nail polish too, because the lights cannot go through the nail polish as efficiently, that too can affect the readings. It's important to check the calibration. A simple thing that I do sometimes is just put on my own finger, and obviously I'm assuming that I test it so often that I know my range should be in the 98, 99, 100, okay, because I'm healthy at this point. If it's abnormally low, well, then there may be a calibration issue. It's important to monitor the quality of the reading as well. It should display a clear and steady waveform. We'll look at them on the next slide, and that'll indicate a good quality reading. If the waveform is weak or erratic, the reading or the number, the value may not be accurate. It's important to know, though, too, just like any tool, it's not perfect. That even in the best conditions, pulse oximeters may not be 100% accurate, especially with patients with low peripheral perfusion, anemia, or under certain other environmental conditions, such as in the cold. So in all these cases, it's important to interpret the results in conjunction with other clinical information. And I'm going to repeat this because it's so important. Sometimes when I'm doing a reading and the number just doesn't seem accurate to me, I'll take a look, make sure that it's on the proper, it's on the finger properly. I'll make sure the patient's not moving. I might test another finger. I'm going to look at the bouncing bar at the bottom right here, because this will just go up and down, and I'll check to see if it's matching with the radial pulse that I'm feeling. I'll make sure that the finger is cleaned, that there's no nail polish on. If we have to remove that nail polish, I'll make sure that there's a good waveform. So sometimes you can see here the waveform across the monitor under the ECG, and that changes with the settings. And then more specifically for the waveforms, so this is a normal waveform, normal pleth. Somebody with low perfusion, you'll just have this little wavy line. Okay, you will not have an accurate reading with this. You will not have an accurate reading if there's noise artifact. This is what motion artifact can look like. Sometimes too, you may have a patient with an irregular heartbeat, so you can actually see waves followed by plateaus. And sometimes you can see what seems to be a regular waveform or regular signal, but really it's decrease in amplitude, which is indicative of a weak signal. So why do we measure pulse oximetry? Paramedics often measure pulse oximetry in order to assess a patient's oxygen saturation level, so their status of oxygenation. So like we were talking about last week, in terms of if they have a ventilation or an oxygenation problem, well, this oxygenation problem can be determined, or we can have more information by using this simple tool. So this is an important measure, as oxygen saturation levels provide information about the patient's amount of oxygen being delivered to the body's tissues, and can help paramedics determine if a patient is experiencing hypoxia or a lack of adequate oxygen supply to the tissues. In addition, pulse oximetry can help paramedics assess the severity of a patient's condition and determine the need for supplemental oxygen. For example, a patient with low oxygen saturation level may need supplemental oxygen to help support their breathing and improve their oxygen saturation levels. Pulse oximetry is a non-invasive and relatively quick measurement, which makes it an ideal tool for paramedics who can quickly assess a patient's condition and make treatment decisions in the field. Looking at normal limits, anything above 94% is considered normal. Most healthy individuals will have saturation between 95% and 100%. The most of them will have 98% and more. When we look at patients who have chronic hypercapnia meaning these are our CO2 retainers, carbon dioxide retainers, either from certain diseases, and we'll list them later on, or our COPD patients, or our chronic obstructive pulmonary disease patients. What's an acceptable range for them is 88 to 92%. And important note for our COPD patients, simply ask them what their normal sat is. They'll be able to tell you what their normal, quote unquote, normal is for them. And that's kind of what you want to target for them. But an acceptable rule, and in our protocol, the range is 88 to 92%. In terms of applications of pulse oximetry, there's several of them. I list them 4 here. So the first one being assessing respiratory distress. So pulse oximetry can help paramedics assess the severity of a patient's respiratory distress and determine if the patient is experiencing hypoxia. Again, that's the low oxygen levels in the blood. Next, it can monitor the effectiveness of supplemental oxygen. So of course, when we're running our treatment, it's important to see if our treatment works or not. So if a patient is receiving supplemental oxygen, pulse oximetry can be used to monitor the effectiveness of this treatment and ensure that the patient's oxygen saturation levels are improving. Okay, that's when we're talking about titrating our oxygen. We're going to actively see a change in oxygen saturation as we increase the supplemental oxygen. So next is detecting changes in a patient's condition. Pulse oximetry can provide continuous monitoring of a patient's oxygen saturation level and help detect any changes in their condition, such as worsening hypoxia or heart rate. Here you can imagine our patient who is intubated and all of a sudden the sat just plummets. Well, then you can start thinking potentially that the tube was dislodged. Next, identifying underlying medical conditions can help us identify things such as COPD, heart failure, or anemia, all of which can affect a patient's oxygen saturation levels. So here's a little bit more exhaustive list of factors that can influence accuracy. We talked about patient motion. We talked about nail polish. Vasopressors, such as epinephrine, other things like dopamine and dobutamine can also have an effect because they're decreasing the circulation to the extremities. Jaundice secondary to high bilirubin levels. So if we have somebody with liver failure, their liver is no longer able to eliminate bilirubin, which is a byproduct of red blood cells being broken down. And what can happen is they'll get deposited in the skin and it'll create a yellow appearance. Okay, that can affect, again, the light going through the skin to take a reading. Abnormal hemoglobin. This is for patients, for example, who have sickle cell anemia. Bright ambient light. Then we have gases such as carbon monoxide, cyanide, hydrogen sulfide. So 3 substances that can affect the accuracy of the reading. We've learned before or in another class, or you will anyways, that carbon monoxide has a much higher affinity for oxygen, meaning it's more sticky to oxygen than oxygen. So carbon monoxide is very sticky and it'll bind to hemoglobin a lot more efficiently than oxygen would. The problem is the SAT probe or pulse oximetry can't tell the difference between carbon monoxide and oxygen. So you may get a false reading if somebody, for example, I called this weekend, patient had left his car on in the garage for whatever reason. He was upstairs. We went there. He had perfectly normal oxygen saturation. Okay, he didn't have any of the late signs like cherry pink or cherry red skin. His SAT was normal. He didn't have any other symptoms like headaches or anything like that, but still, these are patients that will still require oxygen to go then displace that carbon monoxide so that oxygen can bind back to the hemoglobin. Absence of radial pulse, hypotension, poor perfusion states such as shock. These are all things that will affect the distal circulation. Same thing with hypothermia. Same thing with age to a certain extent. So an extreme of age, so somebody who's very elderly will have decreased circulation to the extremities. They'll also have a decreased integrity of the skin, which can affect the accuracy. But then for pediatric patients, essentially the problem is that we don't have the correct tool. So we're trying to place an adult SAT probe on a child. We'll try putting it sometimes on their ears. We'll try putting it on their toes. Okay, but it's important to understand that we may not necessarily get an accurate reading. Sometimes you can have a little piece. It's almost like a Band-Aid that sticks to their finger. It's made for pediatrics. You'll have a better reading with that. And the last thing that can affect the accuracy is the presence of a strong electromagnetic interference. So that to say, treat the patient, not the monitor. This is something that you will hear over and over again. Okay. Pulse oximetry, like all of our tools, is just a tool. It's only one part of our assessment. That doesn't trump your clinical interpretation of the patient, your clinical presentation of the patient. Okay. Patients can compensate in a multitude of ways to keep their sats up. Another call I did this weekend, 6-year-old, 2 days post tonsillectomy. Patient was pale, diaphoretic, vitally completely stable. So he didn't have a fever. He didn't have fast heart rate. He didn't have low sats. His blood pressure was normal. He had physical signs of shock, but was not showing, in terms of his vitals, was not showing any signs of shock. But still, I considered that he was in shock, and gave him supplemental oxygen. Another example, let's just say you have normal stats, but the patient is labored, breathing, has tachypnea, is using accessory muscles, tripoding. Well, they're obviously in respiratory distress. They obviously have an oxygenation and potentially a ventilation problem. Another concept to understand is the oxygen hemoglobin dissociation curve. So we can see here this curve on the right. On the x-axis, we have the partial pressure of oxygen in millimeters of mercury. On the left, we have the left side, we have the y-axis, which is the oxyhemoglobin, the percentage of the saturation of that. The red sigmoid, so it's a sigmoid shape curve, is a normal state, a resting state, a baseline state. And you can see right around 60, at 60 millimeters of mercury of partial pressure, that's where we have the most balance in terms of the oxygen saturation, or the most oxygen saturation of the oxygen, or the oxyhemoglobin, excuse me. But then we have changes in states. So we have what we can call a right shift, so that's the blue dotted line, and a left shift, which is a green dotted line. And a simple mnemonic to remember what causes a right shift is cadet, face right, almost like a military drill. So we have our little Army cadet here. So cadet, C-A-D-E-T, it's a mnemonic, face right, meaning right shift. All of these, 1, 2, 3, 4, 5, so these 5 events, any changes in terms of increases will cause a right shift. So increase in CO2, increase in acidosis, increase in 2,3-DPG, which is simply a molecule that helps oxygen bind to hemoglobin. We have exercise, and we have increased temperature. Okay. One little just caveat: remember, acidosis is a low pH. Okay, under 7, I believe. So an increase in acidosis is actually a decrease in pH, but just keep that in mind. And then you can imagine a left shift is the opposite of that. So a decrease in CO2. So a decrease in acidosis, or an increase in alkalosis. Okay. A decrease in 2,3-DPG, decrease exercise states, decrease temperature. Okay. That's to the left. What happens is on the right here, when we have a right shift, again in blue, there's a reduced affinity of oxygen to bind to the hemoglobin, meaning that the hemoglobin, and here just a simple analogy to remember is a right shift is a loose curve. There's a reduced affinity, so it'll offload oxygen more easily. And it's easy to understand when we look at exercise as an example. So if we're looking at exercise, we're doing squats. We're using large muscle groups. Our muscle tissue requires, there's increased blood flow to the area because we need to send more oxygen to those tissues. Okay, so if we're just forget for a second there, we're increasing blood pressure, we're increasing heart rate and all that. Just think about the oxygen and hemoglobin. The hemoglobin needs to release that oxygen more easily so we can bring more oxygen to the tissues. Okay, it makes sense. Now, to the left, there'll be an increased affinity. So right shift, reduced affinity, left shift, increased affinity, meaning the oxygen saturation will hold on to the hemoglobin will hold on to the oxygen more tightly. Okay. Of course, there's a regular balance in our red line, our red sigmoids at the baseline. Why that's important to know. Okay, simply put, when we have any of these states, okay, we can think of hypothermia, hyperthermia. We can think of a patient who is acidotic, alkalotic. We can think of a patient who is exercising, a patient who is febrile. Okay, when we look at our oxygen saturation from our pulse oximetry, we can know that it might be either lower, okay, than what we're actually reading, okay, or higher than what we're actually reading, okay. We don't need to actually know. So you can imagine the right shift is offloading oxygen a lot more easily. Left shift is holding on to it more readily. Okay, the whole point of oxygen saturation is to know how our tissues are perfusing. But if we're not getting a right offloading of oxygen, well, obviously we're not going to have an accurate O2 sat reading. So just keep this in mind. Now, performing pulse oximetry, very simple. Clean the patient's finger, place the probe, the sat probe on the index or middle finger. The wire should be upwards, so on the top of the finger. We turn on the pulse oximetry. We note the displayed numerical reading as well as the blip reading. Okay, that's on the bouncing bar. And then we make sure to palpate the radial pulse to ensure that it correlates with the display of the pulse that we're seeing on the pulse oximeter. One thing that's important is to not apply the SpO2 sensor in the same limb as the NIBP cuff. So NIBP, non-invasive blood pressure. That means that's that BP cuff that we use. Okay. The SpO2 alarm may sound when the arterial circulation is cut off during the NIBP measurement and may affect the SpO2 measurement. Okay. So this is something that I'm sure everyone's going to do, but it's okay. Put blood pressure on one side and sat probe on the other side, because if not, every time it's going to kind of be on, the blood pressure is going to be on. It's going to inflate. That's the word I'm looking for. It's going to inflate. It's going to cut off blood circulation for a moment, and it's going to affect the sat probe or the oxygen saturation measurement, and you're going to hear kind of the bells and whistles going off. So why do we do this? The whole point is to see if we need to determine if we got to give oxygen therapy or oxygen supplemental oxygen or not. So the goal of oxygen therapy is to treat or prevent arterial hypoxemia. Okay, so hypoxemia, it's the hypoxia of the blood, which leads to tissue hypoxia. Tissue hypoxia is the result of not enough oxygen being available for the cells to meet metabolic needs and may lead to tissue injury and death. So now you can see I'm saying the same thing in 5 different ways, okay, because I really want you to grasp it. Hypoxia occurs from a lack of adequate ventilation, inefficient gas exchange, or inadequate circulation. Okay, so those are different ways that hypoxia can occur. And our clinical practice guideline, our PICTAP protocol, is known as Tech 10. So let's go through Tech 10. Tech 10 has actually just recently changed. It's gotten a lot more simple, and it's actually in line with standards of care across other healthcare professions. So there's 3 different options when administering oxygen. So it makes it very simple. We're either going to give 100% oxygen via a non-rebreather mask, or what's called an NRB, to these 4 instances: a patient in cardiac arrest, patient in respiratory failure, and they're at pain or unconscious on the AVPU scale, a diving accident. Okay, they put diving, but I'm gonna also say altitude sickness. Okay, but diving accident, we're thinking like the bends here. So this is a patient who's gone on who went scuba diving and went at depths, came up too rapidly, and they are experiencing signs and symptoms of what we call the bends. All that to say, this is one of the indications for delivering 100% oxygen. Next is carbon monoxide, cyanide, or hydrogen sulfide poisoning. Again, it's going to give us an inaccurate reading, so we can't use the oxygen saturation reading to determine if we're going to give a nasal cannula, a non-rebreather mask. Okay, so all these instances, we have an inaccurate reading, so we're just going to give 100% oxygen. Okay, again, we most likely have states of hypoxia. The second option is our patients who have COPD or chronic hypercapnia. Okay, because these are patients who have what we call hypoxic drive. Okay, so typically patients who have not patients who have, healthy patients, such as you or I. Again, I know some people will say, okay, there's different ways that our body actually determines the need for respiration. That controls our respiratory effort. Okay, mainly it works because of our acid-base balance. Okay, but we typically our respirations will be triggered by high levels of CO2. Okay, so our body, that'll be the primary driver. Okay, so for understanding, it'll be the primary driver. So increase in CO2, so we've retained CO2, it'll trigger our bodies to then take in O2, okay, to breathe. But when we have disease states, just as COPD, where we trap that CO2, or other disease states that, again, retain CO2, since we're so chronically high, our bodies switch, they change, and they will essentially, the driver for respiration will then become the low levels of O2. So what's dangerous there is high levels of O2 can essentially suppress respiratory drive. Okay, so that's why we're going to titrate oxygen for these patients. And then the last category is all other patients, meaning all other patients who don't meet criteria 1 or 2. So criteria being 100% O2 for those 4 instances. Criteria number 2 is our COPD or chronic hypercapnia patients. I've included the Tech 10 protocol here in French, so I will read it also in French. So the first option being situation nécessitant de l'oxygène à haute concentration, administrer de l'oxygène avec une FiO2. So that FiO2 is fraction d'oxygène inspiré à 1. Okay, so 1. Think of 100% oxygen. Ou avec un masque à haute concentration, MHC, which is our NRB in English, pour la durée complète de l'intervention, indépendamment de la valeur de la saturométrie. Okay, so we're not even looking at the oxygen saturation. Pour tout patient présentant l'une des situations cliniques suivantes, accident de plongée, arrêt cardio-respiratoire, incluant DAVG et OVI, so meaning including the cardiac arrest with patients with the LVAD device, so left ventricular assist device, or OVR is obstruction des voies respiratoires. Exposition ou suspicion d'intoxication au monoxyde de carbone, ou cyanure ou au sulfure d'hydrogène, and d'insuffisance respiratoire à P or U. Aux situations, titrer l'oxygène, meaning look at the oxygen saturation and titrate it pour atteindre la saturation SpO2 cible selon les clientèles suivantes. Clientèle MPOC, which is our COPD, O2 dépendant ou non, so oxygen dependent or not, ou à risque d'hypercapnie chronique. Okay, our valeur cible here is 88 to 92%, 88 à 92%. Our hypoxic drive patients at risk for chronic hypercapnia. These are our bariatric patients, so around 300 pounds. Our patients with cystic fibrosis. Our patients who have severe deformities of the thoracic cage. So we have like what was called like pectus excavatum. Okay. And then we have our chronic neuromuscular diseases. Again, this has to do with our chest wall movement. Okay. These are our patients that we're titrating 88 to 92%. Okay. We used to think that oxygen as well was just something very, very safe. And it's still considered safe for many patients, but there are still concerns about the potential risk for certain patient populations, specifically for MIs patients. I'll show you the research soon. In some studies, supplemental oxygen therapy has been shown to worsen outcomes for patients with acute myocardial infarctions, okay, patients who've had heart attacks, and can lead to increased oxidative stress and worsen ischemia, meaning lack of blood flow and oxygen to the heart. In terms of oxidizing effects of oxygen, high levels of oxygen can have oxidizing effects on the body, causing oxidative stress and damaging tissues. This can lead to further complications in patients who already have pre-existing conditions, such as those with chronic lung disease or heart disease. Okay, so the safety and efficacy of oxygen therapy depends on the individual's patient's needs and conditions. Okay, so it's important to monitor these, and this is why we're not just giving 100% oxygen to everybody, like we used to do. So here, this is specifically from the Paramedic Evidence-Based Practice database. If we look at oxygen high flow and oxygen titrated, you can actually see the level of evidence is in the 1, strong evidence for neutrality for oxygen high flow or against for oxygen titrated. Okay, these are ischemic chest pain patients. I have the link here. I invite you to go click on it so you can actually see the individual papers and see their, their primary outcomes and where it was done and really understand kind of the impacts of hyper-oxygenating a patient who doesn't need it and who also has cardiac ischemia. Okay, because we used to think, oh, cardiac ischemia, lack of oxygen, let's just give a whole bunch of other oxygen. But no, actually, through releasing of free radicals, oxidative stress, and all that, it actually led to increased vasoconstriction, so increasing in ischemia, and of course, like I said, the oxidative stress causing more tissue damage. So no, oxygen should still be considered a drug, and we shouldn't just give it to any patients for no specific reason. Okay, there should be an indication. Specifications about this protocol. So patients who have a saturation of 86% and higher, we're going to titrate up, meaning we're going to start with the lowest amount of oxygen possible, such as a nasal cannula at 1 or 2 liters. And then we're going to increase the flow meter of the oxygen delivery device until we attain our target saturation, whether that's our 88 to 92 or 94 to 98 for our healthy patients. If a patient starts below 85, then we're going to titrate down, meaning we're going to give 100% O2, and then we're going to titrate down. If it's way too high, then we'll change to a nasal cannula, for example. Again, I'll repeat it. Use clinical judgment with patients with a saturation within normal limits, but who show signs of hypoperfusion, pallor, cyanosis, altered mental status. Okay, so a patient, this is another call I did. You respond to a patient who's lethargic. She was sitting in her mom's car. She was pale, hypotensive. She was tachycardic. She had described having a heavy menses or a menstrual cycle that had just started that day. Saturation was normal. But like I said, yeah, she was tachycardic, hypotensive. So would you administer oxygen here, even if the sat's normal? I would say yes, because again, I don't think that what we're reading on the saturation is accurate. So here is directly from Tech 10. I'll invite you to read it. It talks about, again, titrating oxygen for patients who titrating up if our patient is 86% and more in terms of saturation, or titrating down if our oxygen saturation is below. Sorry, it's 85% and up. 85% and up, we titrate up, and under 85%, we titrate down. So this is an error. I will fix it. So titrate up for any patient with oxygen saturation of 85% and higher. Titrate down for patients with oxygen saturation of 84% and lower. Okay, so take note of that correction. They talk about our chronic hypercapnic patients. They also talk about availability and fiabilité, so accuracy. Okay, that's why I gave you a whole bunch of information before about how we can determine if the reading is accurate or not. Also, the specifics for MRSI, maladie respiratoire sévère infectieux. Here, they say veuillez utiliser le protocole usuel et appliquer les particularités MRSI suivantes selon la directive en vigueur. Pour généralité, mettre un masque de procédure au patient lorsque la lunette nasale est installée, si toléré, so meaning put a surgical mask over the nasal cannula, and don't administer more than 5 liters per minute when the nasal cannula is on. And si désaturation à 5 litres par minute, installer un masque à haute concentration au patient. So let me just go back here too, because I want to specify for patients who are not COPD, who do not meet one of these 4 criteria, the saturation we're looking for is 94 to 98%. Okay, so I'll say it again, 94 to 98%. I wanted to also include the Tech 10 from first responders, because you're going to respond to a scene, they're going to be there. They may have a patient on 100% O2, which doesn't necessarily match your protocol. Well, what's nice about the new protocols that come out for Tech 10, they are pretty much almost the same. So here, so all of our other clientele or or patients, I shouldn't say normal patients, but patients who are not COPD or do not meet one of these criteria, 94 to 98% is what we're trying to attain. For our COPD, 88 to 92, so that's the same. The only thing that's different a little bit, so they have for toute situation d'arrêt cardio-respiratoire, which is the same, accident de plongée, which is the same, exposition cutanée à des substances toxiques, okay, which is similar. They talk about carbon monoxide, they talk about hydrogen sulfide, cyanide. The only one that's different here is atteinte de l'état de conscience, seulement état de conscience PEU, okay, where we had insuffisance respiratoire à PEU. They'd have any altered mental status at PRU. Okay, so you might go to a scene where the patient's unconscious. They don't necessarily have respiratory insufficiency, and they have 100% O2 on, which may not necessarily be in line with their protocol. So that's the only one that is different. So let's look at a couple of scenarios. First one is you respond to the home of a 94-year-old male, 6 delta 1, 6 being difficulty breathing. Upon assessment, you discover that the patient has emphysema and their typical saturation is 88%. Okay, emphysema being I guess one of the categories of COPD. Okay, one of the diseases included in COPD, I should say. Vital signs are as follows: GCS 15, pulse is 88%. 88%. Pulse is 88, strong, regular. Breathing at 24, regular. Labored and shallow. Sats are at 86%. So how much oxygen would you administer? So the answer here, they're satting at 86%. They are COPD. So that means we're going to titrate up to get 88 to 92%. And we're going to use a nasal cannula. So I'll talk about the oxygen delivery devices in another lecture video. So it's a nasal cannula. I'll probably start at 1 or 2 liters and titrate up, meaning I'll change it. I'll adjust the flow of the oxygen, 1 liter, 2 liter, 3 liter, 4 liter, until I achieve the saturation of 88 to 92. If I go too high, I'm going to titrate down. So if I go to 93, 94, 95, I'm going to titrate down for this patient. Scenario, hypoxic drive patients. So you respond to the home of a 29-year-old male, 6 delta 1 as well. Upon assessment, you discover the patient has cystic fibrosis. Patient explains that they had a fever, they've had a productive cough, both of mucus and blood, and have a lot of difficulty breathing. They're fully alert and oriented. They have a pulse of 92, strong, regular. They're breathing at 28, regular, labored, and shallow. They're setting at 82%. So they're setting at 82%. How much oxygen would you administer to this patient? So if you're thinking 100% oxygen via non-rebreather mask, you would be correct, because their saturation is below 85%, so 84% and less. We're going to titrate down. We're going to start with 100% non-rebreather, and then we're going to titrate to get them between 88 and 92. Okay. If we go too high, we put 100% O2 and they're setting at 98%, well, then we're going to try nasal cannula afterwards. Okay. So we're going to go down, not up in terms of titrating. Another scenario, you respond to the home of a 54-year-old female patient, 2 delta 2. So this is an anaphylaxis call. Upon assessment, you discover the patient has difficulty breathing and is known to be allergic to peanuts. The patient admits to eating food that may have contained the allergen. She has taken one of her EpiPens. Vital signs, again, GCS normal, pulse at 100, strong, regular. I'm not surprised she took an EpiPen. She's breathing at 24, regular, labored, shallow. Her sats are at 94%. How much oxygen are you giving this patient? So the correct answer here is, since they don't meet the criteria of the first one, the cardiac arrest, carbon monoxide poisoning, some sort of altitude sickness or diving accident, okay, they're at PRU from a respiratory complaint or respiratory insufficiency. You're giving them a nasal cannula, probably starting at 1 to 2 liters a minute, and you're titrating up till you hit a range of 94 to 98. So you don't need to titrate that much further. So I kind of already gave you the answer, but you respond to the Dorval Airport for a 36-year-old male complaining of difficulty breathing. According to the patient, he's returning from a scuba diving trip down south. The vital signs are GCS 15, pulse 84, breathing at 24, regular labored shallow, setting at 92%. How much oxygen are you giving this patient? So this patient, you're not even looking at the sat, okay? They've told you it's a diving type call. You're giving 100% O2 right away with non-rebreather. Last scenario, you respond to a child having an asthma attack. The oxygen saturation is unobtainable as you cannot get a proper reading with the adult probe. You have placed the probe on the child's ear and toes with no success. How much oxygen are you administering to this patient? So the correct answer for this patient, since we cannot have an accurate reading, we are again going to 100% O2. We're going to give this patient a pediatric sized mask. So that's it for this presentation on pulse oximetry and our Tech 10 protocol. So oxygen administration. It's really important from now on to have the Tech 10 protocol memorized, understood, specifically not only just to memorize the criteria for option A or for B for COPD, A being for our diving accidents, exposure to toxic gases, respiratory insufficiency, PRU, okay, or cardiac arrest. But it's important to understand our right shift, our left shift, our disease states, and how they can actually affect the accuracy of an oxygen saturation reading so that we can make a clinical decision that when it falls outside of our, or that we're within normal limits of oxygen saturation, but the patient's disease state dictates that they need supplemental oxygen because they are showing signs of hypoxemia, hypoxia, shock, and so forth. So please see the assigned homework in Google Classroom. It'll be to read the chapter on airway management. I believe it's chapter 13. And then I will have another pre-recorded lecture that's going to be very quick. It won't be as long as this one. That's just pretty much showing you the oxygen delivery devices. So the O2 cylinders, the non-rebreather, nasal cannula, and the different types of masks that you may see in the hospital setting. And if you have any questions, do not hesitate to reach out.